Let's go.
Let us discuss urine formation in this session.
Now,
So here is
to
that
teach
medical
you
physiology
for
books.
medical
So
students.
we are going to be
This
discuss.
is medical physiology. I have been taken sixth edition of JP, and this is actually Symbolingam. This is also some of the medical students are using it. I got this edition, and let us see it now.
Today we are going to be discuss urine formation, and this is actually the source I have been collected from the medical physiology textbook Sembulingam, the textbook name I am mentioning, and the urine formation going to be done by the three steps. You are very familiar with that, and this is the first one is nothing but glomerular filtration, which you can consider it's like a ultrafiltration also. And next it is like a tubular reabsorption, and the third one is that tubular secretion. Let us go with that introduction part here. Introduction when it comes to the blood going to be filtered by the kidneys, and that filter one, I mean a filtrate, is called here glomerular filtrate. From that what happened, useful things and all will be of a reabsorbed, and unwanted waste going to be eliminated as urine. Per day it's going to be filtered 180 liters per day, it's going to be filtered. Among that, 99% of this glomerular filtration, I mean a filtrate, going to be reabsorbed, 1% going to be eliminated as urine. So that means here 1 liter to 1.5 liters of a urine only will be formed per day. Okay, that's going to be seen it. And here the mainly which part is participating in this filtration, in the sense that's a nephron. Okay, the structural and functional unit of the kidney is nothing but the nephron. Nephron will be consisting of two portions. One is a glomerulus, another one is a renal tubules. Now the glomerulus, if you are considering, that's a blood capillary. A renal tubule, in the sense here, it's going to be seen that Bowman's capsule, followed by the PCT, and then Henle's loop, and then followed by this is that DCT. Okay, till here only we'll consider it's like a renal tubule. Collecting duct is not the part of the nephron, right? So that's what you have to remember it. Okay, now let's go here how this is going to be seen it. Now let us discuss the structure of a nephron first, so you may have an idea. For let us see that here nephron will be consisting Bowman's capsule like this, and it's followed by this proximal convoluted tubule. Then this is here Henle's loop, and this is followed by distal convoluted tubule. Okay, and then it opens into collecting duct. This is what that tubular structure of a nephron. And when it comes to here, there is a blood vessel. This is, we can consider it is as a afferent arteriole. This is renal artery. Renal artery divided into small capillary, I mean like a small blood vessel, and this is called here afferent arteriole. And this afferent arteriole going to be divided into small capillaries, which you are going to be called, it's like a glomerulus, and this going to be unite together and form here renal of efferent arteriole. Okay, and then this going to be formed now peritubular capillaries. This peritubular capillaries going to be surrounds entire this renal tubules, and when it's coming here to this parallel to this Henle's loop, then you will consider this is as a vasa recta. Now all these capillaries, peritubular capillaries, unite together and it forms now this is a renal vein. Now you understand. Okay, so hope you got it. Now let me tell to you a still more clear way so you will get it. Okay, so now I'm taking out this. Okay, now you can see that this is that Bowman's capsule. Bowman's capsule going to be consisting here one of the part of a nephron, and inner layer and outer layer, two are there. Inner layer is called here visceral layer, outer layer is called here parietal layer. This is parietal layer and this is visceral layer, visceral layer. And this we are considering as usual afferent arteriole, which brings that blood towards this glomerulus or Bowman's capsule, and which carry that the blood out of this glomerulus is called here efferent arteriole. Okay, got it, I guess.
Urine formation we are discussing. Urine formation. Urine formation, when it comes to here, it's going to be have like a 3 steps. One is a glomerular filtration. This is followed by tubular reabsorption, and then tubular secretion. So now what happens here? Actually, this is Bowman's capsule and this is PCT. Let us have an idea. This is like a nephron, like that. And now the blood vessel which brings the blood into this one, into the Bowman's capsule, is called afferent arteriole. Afferent arteriole. The blood will be towards this, okay, glomerulus. Okay, and now the small blood vessels are there now here. This is the capillaries. This is actually that glomerulus. You can consider it glomerulus. Okay, done. And now this is going to be unite again, and then it will form here, which brings that blood outside. Okay, and this is called here efferent arteriole. Efferent arteriole. Right. And now this efferent arteriole will form here peritubular capillaries. So this is what here peritubular capillaries. Peritubular capillaries. Remember here afferent arteriole and efferent arteriole, both the things are carrying here oxygenated blood only. Oxygenated blood only. What's the difference then? Afferent arteriole will be consisting here more nitrogenous waste. Efferent arteriole will not be consisting nitrogenous waste. Nitrogenous waste is filtered. That means pure blood, you can consider it pure blood in the aspect of nitrogenous waste. And then what happened? Whatever that filtration will be taking place, that will be if it comes into this PCT, right? That going to be called as here as a glomerular filtrate. This is GF. GF only. GFR sollakudadu. Okay, we should not tell that GFR. So now GF. Now this GF will be consisting many nutrients. Okay, that nutrients are useful things. Nutrients or useful substances. Useful substances or reabsorbed into this. Okay, so into this is only tubular reabsorption. You got it now? Glomerular filtrate consisting of many nutrient and useful substances that going to be reabsorbed into this bloodstream. Okay, that is tubular reabsorption. This is tubular reabsorption. The same way here, what happened? Some of the unwanted things, unwanted ions going to be eliminated here. Okay, elimination must be done. So hence what happened? From this peritubular capillaries to into this. Okay, from the peritubular capillaries to into the renal tubule going to be secreted, and this you will consider here as a secretion. So this is tubular secretion. Now you got it, right? So filtration, from the filtrate, reabsorbed. Afterwards what happens? Some of the unwanted ions going to be introduced into that, again renal tubules. This is what the 3 steps. Now let us say here, let us going to be have an idea, okay, how this filtration takes place. When it comes to here, Bowman's capsule, as we have been mentioned here, Bowman's capsule alone we are discussing. Bowman's capsule. The inner layer is called visceral layer. The visceral layer is lined by simple squamous epithelium. Now this is simple squamous epithelial cells. The simple squamous epithelial cells are modified into okay, podocytes. Podocytes, you will read entire physiology, only this area, podocytes, which you are going to be called here, okay, podocytes. Now this podocytes are for the filtration purpose. Now in this region you have to remember there will be capillaries also, okay, like this. This is glomerulus, right? Now you see the same structure I am going to be draw now. This is Bowman's capsule visceral layer, and now this is here blood vessels layer, okay, I mean a glomerulus layer. And now you go with that here. Let us have an idea. Blood vessel layer will be lined by simple squamous epithelium only. This is also single layer, and this is called here endothelium. Endothelium. Okay, this is here endothelium. We can consider it. This is the blood vessels. We can consider like endothelium. This one, right? And now when it comes to here, this one I am considering it podocytes. These are all podocytes. Podocytes are like this. Now this podocytes going to be make a loop, or else here pedicel like structure going to be formed. It's going to be formed now pedicel like structure. Diagram gone. Wait a minute. Here little bit of a maximized diagram I have been drawn, so you can see very clearly. This is the podocyte. The podocytes will be forming here. These are the projections. We can consider these are all pedicels or feet, you can mention it, like a finger like a projections we can consider it. Like this it can going to be have it. This going to be exactly surrounds this blood capillary, that means glomerulus. So like this it's going to be have it. Now you see here there is a slits, there is a pores, and these pores are called here filtration slits or filtration pores. Fenestra also you can call it, and this is also penestra. Penestra size will be here around 0.1 microns going to be seen it. 0.1 microns going to be seen it. So that easily the blood going to be, when the blood is passing through this one here, the blood going to be easily filtered. Okay, so that's what the podocytes importance. Podocytes going to be present at the visceral layer of this Bowman's capsule. So now this penestra going to be formed due to the pedicel or feet like structure present at this podocytes, right? So as a result here filtration slits are formed here, right? Now that you have to imagine that here is that filtration slits are present. Filtration slits are present. So through that one what happened, blood going to be filtered into this. That is the thing here, the inner lining of this Bowman's capsule, right? And now we go here, that's going to be shown again. This is basement membrane. Basement membrane is present here at this region, meaning between this blood vessel, between this glomerulus and then Bowman's capsule inner layer, the basement membrane will be there. So how many membranes are present here in the filtration membrane? In the sense, inner lining of this is endothelium of the blood capillaries, and this is the yellow colored one, basement membrane, and this is the visceral layer, epithelium of Bowman's capsule. Again I am repeating Bowman's capsule here, Bowman's capsule. So endothelium of blood capillaries, you can consider this is as a glomerulus you can consider it. And next one is the basement membrane. Basement membrane, you always remember this is a cellular substance. This is not a membrane, cells will not be there.
just like a glycoprotein is going to be present here. That's the acellular substance. This is basement membrane. Basement membrane can be seen it here, membrane. And the last one is here, epithelium of Bowman's capsule. So these three layers together, it will form now, that's a filtration membrane. Filtration membrane. Now the filtration is taking place by the three layers here, right? So hence it is called here ultrafiltration. Ultrafiltration, you can call it. Why it's called ultrafiltration? Because three membranes are participation taking place. Hence you can consider this as a ultrafiltration. And next, when it comes to here, this ultrafiltration time, what happens? We have to go how it's a filtration takes place. Okay. Now, let us say here, afferent arteriole brings the blood, right? Afferent arteriole brings the blood. This is afferent arteriole. The afferent arteriole, when it's bringing the blood towards this one, what happens here? How much blood it's going to be bringing, in the sense around 1100 to, okay, 1300 ml of blood per minute it's going to be bring, which is equivalent to 1/5 portion of a, okay, 1/5 portion of cardiac output. In a percentage wise, if you're considering around 20%, 20 or 26%, we can consider it percentage wise. Portion I have been told, 1/5 portion of a cardiac output can be mentioned here. Cardiac output is nothing but 5 liters, right? 5 to 5.5 liters per minute, right? So in that 1/5 portion is going to be taking place here, right? So now in the NCERT textbook, it is like a 1200 only. In a medical book, it is like a 1300. So that I have been taken this 1200. You have to remember 1/5 portion of a cardiac output. Okay, that will be. So that means it's a bringing here like this. Now it's going to be filters, right? Here it's going to be filters, and this filtrate is called here glomerular filtrate. Glomerular filtrate. Okay. Now this glomerular filtrate, how much it's going to be produced? How much it's going to be produced, in the sense per minute it's going to be 125 ml. Okay, per day, if you're considering here 180 liters it's going to be formed. I'm talking about glomerular filtrate, right? Now let us say here how much blood flows. Blood flow, okay, you can mention like a renal blood flow. Renal blood flow is also can be mentioned here RBF. How much blood flow, in the sense per minute, that's what we have been mentioned, 1100 to 1300 ml going to be produced. This is what per minute. This is also, let us go with that RPF. This is renal plasma flow. Renal plasma flow. RPF will be, we know very well that total blood will be consisting 55% will be like a plasma, and then 45% will be formed elements, right? We already studied in a circulatory system. 45% will be formed elements, 55%. So now here from this one 55% only, that's a plasma going to be filtered here. That means around 650 ml per minute going to be produced. Okay, this is what you have to remember it. Renal plasma flow, only plasma, how much it's going to be flow, we are going to be discuss. Renal blood flow, okay, how much blood it's going to be flow per minute, we are going to be takes place, right? So this is about. Now we go with that reading of this textbook till here, then I will explain to you. Okay, so now let us have an idea. So now we are going to be discussing whatever we discussed, it's going to be seen it here. So now glomerular filtration, it's a followed by tubular reabsorption and tubular secretion. Among these three processes, filtration is function of the glomerulus. Reabsorption and secretion is a function of tubular portion of the nephron. Very important. Okay, filtration is a function of this glomerulus. tubular reabsorption, and then secretion is that here tubular portion, right? The glomerular filtration. Introduction, if you are considering here, glomerular filtration is a process by which blood is filtered while passing through the glomerular capillaries. That is nothing but glomerulus. That is filtration membrane. Okay, and it is the first process of urine formation. The structure of a filtration membrane is suited for this filtration. Now the filtration membrane. Filtration membrane consisting of 3 layers. Okay, the 3 layers will be present here. That is glomerular capillary membrane, basement membrane, and visceral layer or inner layer of the Bowman's capsule. Glomerular capillary membrane. Glomerular capillary membrane is formed by single layer of endothelial cells. We can consider simple squamous epithelial cells which are attached to the basement membrane, and the capillary membrane has many pores called fenestra. If the capillary membrane is called here, that is a capillary membrane is having a pores, means that is a fenestra or filtration pores. If the Bowman's capsule is having the pores, means that is, we can consider it is as a filtration slits, okay, or slit pores. This is what slit pores means. Bowman's capsule consisting of a pores. If the capillary membrane or a blood membrane is having me, that is a fenestra or filtration pores. The fenestra or filtration pores diameter, if you are considering 0.1 micron only, will be present. And when it comes to here basement membrane, the basement membrane of a glomerular capillaries is that going to be attached to this Bowman's capsule as well as this blood capillaries. Okay, and this fused basement membrane separates the endothelium of the glomerular capillary and epithelium of visceral layer of a Bowman's capsule. Right, now the visceral layer of a Bowman's capsule. Visceral layer of Bowman's capsule, the layer is formed by the single layer of a flattened epithelial cells resting on the basement membrane. Each cell is connected with the basement membrane. Here you have to remember every epithelium will be consisting basement membrane. See here, basement membrane will be there. Basement membrane, without the basement membrane, epithelial cells cannot able to accommodate. Epithelial cells need to rest on the basement membrane. That basement membrane they are mentioning here. Right, so the basement membrane. And now this cells are here called podocytes, which going to be have like a cytoplasmic extension. That's what I mentioned to you, like a finger, like a projections, like it going to be formed. Those are called pedicels or a feet. And these epithelial cells with the pedicels are called podocytes. The four podocytes especially I am mentioning to you, it's related to only excretion. And podocytes interdigitate, leaving the small cleft like a spaces between them. That cleft like a spaces is called here slit pores or filtration slit. The filtration takes place through the slit pores. Right. Now the process of glomerular filtration. When the blood passes through the glomerular capillaries, the plasma is filtered into the Bowman's capsule. Not entire blood, plasma is filtered. All the substances of the plasma are filtered except the proteins. Hence, glomerular filtrate is equal to, okay, plasma minus proteins. Now let us have an idea some of the terms here. Some of the terms I am going to be tell you, okay. When you go with that here, plasma minus clotting factors, then you can consider this as a serum. Okay, if you are telling like a plasma minus nitrogenous waste, you can consider this is as a dialyzing fluid. Okay, when you consider here plasma minus large proteins, then you will mention this is as a lymph. When you mention here plasma minus proteins, complete proteins, either is a large or small, this is here GF. Hope you got it. Now I am going to be repeat here, you can see that. I am going to be repeat plasma minus clotting factors, you can consider it's like a serum. Plasma minus nitrogenous waste, dialyzing fluid, which you are going to be use it in artificial kidney dialysis. artificial kidney or dialysis, that is. Plasma minus large protein means that is called here the lymph. Plasma minus proteins, complete proteins means that is a GF. Hope you got it. Now that's what they are mentioning here. That's a GF in the sense, GF in the sense here, plasma minus the proteins. So that's what you have to remember. Okay. And now we go with that ultrafiltration. When it comes to this ultrafiltration, glomerular filtration is called ultrafiltration because even the minute particles of the filtered, minute particles also will be filtered here, but the plasma proteins are not filtered due to their large molecular size. That's what, without the protein it is there. The protein molecules are larger, the slit pores are present in the endothelium capillaries. That slit pores are called here fenestra. The proteins are here more larger than this fenestra size. Fenestra size how much here? 0.1 microns only. That's going to, protein is going to be more larger. Hence it is not able to come out. Okay. Hence, this is what here. Thus, the glomerular filtrate contains all the substances present in the plasma except the proteins. Important. Done. Now we go with the method of collection of a glomerular filtrate. You are going to be, as a medical student, you are going to be collect this glomerular filtrate for the studying of this kidney function. So that particular period you are going to be do that micropuncture technique, you are going to be use it. So that particular period there will be micropipette, you are going to be use it, and you are going to be aspirate the filtrate. Okay, so this is completely they are going to be teach you in your medical college. And next, glomerular filtration rate. What is that? GFR. They are mentioning here GFR. GFR is equal to the amount of blood. GFR is defined as total quantity of a filtrate formed in all the nephrons of both the kidneys in a given time period is called here GFR. Let us say here 125 ml per minute it's going to be formed. Per day means 180 liters going to be. All this 180 liters will be excreted as urine means that's wrong. 99% of this filtrate going to be reabsorbed, which going to be consist here is like useful glucose, amino acids, ions, bicarbonate ions, sodium ions, which are required to us, that going to be reabsorbed. Okay, so that's what here only 1% only going to be eliminated. Hence the urine will be 1 to 1.5 liters per day going to be eliminated from this glomerular filtrate. So per minute means 125 ml and per day means 180 liters glomerular filtration rate. What is meant by filtration fraction? Filtration fraction is the fraction or a portion of the renal plasma which becomes the filtrate. Okay, and it is the ratio. So we are going to be discussing now. This is the ratio between that renal plasma flow and glomerular filtration rate. As I mentioned to you, renal blood flow means here RBF will be 1100 to 1300 ml per minute. Okay, so RPF, this is renal plasma, if you are considering 650 ml per minute can be seen it. So now we are going to be see that filtration fraction is equal to GFR. GFR how much per minute? That will be 1, that going to be here 125 ml per minute can be seen it. And then this is here renal plasma flow, that is 650 ml per minute into 100, so that you are going to be get it like a 19.2, approximately 20%. So the normal filtration fraction will be here 15 to 20 can be seen it. This is a normal value. If your patient is having 15 to 20% of a filtration fraction, then he is a normal condition only. If it is less or above, okay, then you can consider that a abnormal condition. Okay, so that's about here filtration. Next we go with that pressures determining the filtration. There will be here 3 pressures can be seen it. One is like a glomerular capillary pressure, and next one is that glomerular hydrostatic pressure, and next one colloidal osmotic pressure. First we go here is that glomerular capillary pressure, and next colloidal osmotic pressure and hydrostatic pressure. Okay. Glomerular capillary pressure. This capillary pressure is a pressure exerted by the glomerular capillary pressure is the pressure exerted by the glomerular capillaries. That will be around 60 mm of Hg can be seen it. It varies from the 45 to 70 mm also. That's a glomerular capillary pressure. You can consider GCP. GCP you can consider. This pressure going to be here favors that glomerular filtration. Only 1 second I am going to be explained to you. So now let us say here, this is what here you can see that this diagram. Okay, this is efferent arteriole. Okay, this is afferent arteriole. I have been drawn here the diameter. You have to observe now. This is little lengthy. I have been drawn the diameter. You can see that bigger one, and here is that I have been drawn very small. Okay, so now you can see that. So this variation must be there. Okay, so now here the first pressure is called here glomerular capillary pressure. Glomerular capillary pressure mainly created different diameter of afferent arteriole and efferent arteriole blood vessel. So now what happened when the blood is coming here, this will come like a little slow, and here it's going to be go very fast because diameter is very narrow here, whereas here it's going to be very broader. Okay, so what happens here, this going to be making here the pressure going to be created downwards. The blood capillary, the blood going to be created here downwards, and this is what we can consider it's like a GCP, glomerular capillary pressure going to be around here 60 mm of Hg. This is we can consider favored pressure. This is a favored pressure. And next we go with that glomerular, okay, osmotic pressure. 1 second ma, blood colloidal osmotic pressure. Blood colloidal osmotic pressure, BCOP. Blood colloidal osmotic pressure. Blood colloidal osmotic pressure in the sense, you know very well that blood will be consisting albumin more, right? Albumin will be present. Albumin which going to be helps here, one of the most abundant protein present in the blood, going to be help here osmotic pressure balance. Albumin when dissolves into the blood and it's going to be create that colloidal solution. Colloidal solution in the sense that's the thicky nature, that's like a density of the blood or a thickiness, that's a thick content we can be seen in the blood, right? That's because of this albumin content only, right? So now this albumin, what it's going to do, it's going to be creates here colloidal nature of the blood. That colloidal nature of the blood, what happens here, it will not allow the filtration to become faster. That means this is opposing blood pressure. Now let us say here, let us say here, this is one. So we have like 3 pressures. So this is glomerular, hydrostatic pressure, okay, GHP you can call it, or you can consider this as a capillary pressure, glomerular capillary pressure you can call it. This is GCP you can call it. The another pressure is there, that is colloidal osmotic pressure, and the third one is here, this is hydrostatic pressure, of a Bowman's capsule. this blood colloidal hydrostatic pressure we will consider it. That's what BCOP you can call it. This is Bowman's capsules hydrostatic pressure. Okay, so now this is hydrostatic pressure, you can call it. Now let us say here one by one. So as we have been mentioned that first one is the this is Bowman's capsule, and here you can see that afferent arteriole, it has to be broad in diameter, and just I am putting it here for explanation purpose, 2 capillaries. You can see that this must be narrow. Okay, so now this is afferent arteriole and this is efferent arteriole, right? And this is a glomerulus. Now what happens here, when the blood is going to be come downwards like this, it's going to be create a pressure. As we have been mentioned here, hydrostatic, glomerular hydrostatic pressure, meaning the water present in the blood going to be push the solution downwards. The hydrostatic pressure going to be, see from the blood vessels I am putting that downwards. This is that pressure. This is GHP. GHP, or you can consider here capillary pressure, GCP. You can consider it, glomerular capillary pressure. So now this going to be pushes downward. This pressure pushes downward the solution. Hence this is going to be called as here favoring pressure. This is favoring pressure. If this pressure is not there, the solution cannot able to be filtered. So now what happened here, this going to be around approximately 60 mm of Hg can be seen it, 60 mm of Hg, right? So this is what it may be like a varies 35 to it may be like 45 to 70 also can be seen it. It may be varies, but mostly that 60 mm of Hg we will mention it. This is the pressure. The pressure is created by different diameter of afferent arteriole and efferent arteriole. Because of that the pressure is created here. Remember that. As well as here you have to remember the solution, the water content present in the blood going to be pushes downward. This is only we can consider like a GHP. Okay, hope you got it. And next we go with that. The second one is nothing but here colloidal osmotic pressure. Blood colloidal osmotic pressure in the sense, first let us know that what is meant by colloidal solution. Colloidal solution is equal to, here you have to remember, I'll just give you an example so you can able to imagine. When you take a water plus sugar, so now what happened here, sugar going to be dissolved with the water and it forms like a solution. This is here true solution. The same way if you are taking like a water plus a starch powder, okay, so what happens here, it is also will form the solution, but the starch granules will not dissolve in the water, okay. So this solution is considered here colloidal solution. And one more also you have to imagine now, if you are taking like a sugar solution, your filtration takes place, sugar solution filtration, as well as here this is starch solution filtration. If you are taking which one will be easily filtered? So now this is easily filtered. but this will not be that much. We have to be like a with a spoon or something, we have to do it. Why? Because means that starch granules opposes the filtration. You got it? So now here you understand the logic. The same way, now this entire story apply to the blood. In the blood, what happens? In the blood, the serum proteins, especially albumin, most abundant protein, albumin will be present, most abundant serum protein present in the blood. Now this albumin mixes with the water in the plasma and it forms now colloidal solution. Now as a result, what happened? That's what the blood appears like a kind of a sticky nature, a kind of a thick solution. Okay, so that is because of this one. So now colloidal form of a blood, you can see that. Okay, so that means here in the blood, what happened? Proteins will be present. Those proteins going to be formed here, this colloidal solution. Now the colloidal solution will not allow the water to be come down or the solution to be come down. It's going to be opposes. Hence this pressure is called here opposing pressure. Now I am going to be show in the diagram so you can understand. Now the same diagram I have been taken. What happens here in this one? This one, it is also can be seen in the blood, right? Now this blood opposite. It is not allowing that solution to come outside. Oppositely, it's a pushing it. In the blood itself, it's a pushing it. So now this pressure is called here G COP, means glomerular, sorry, one second ma. This pressure is called here BCOP, that means blood colloidal osmotic pressure. Blood colloidal osmotic pressure, how much it's going to be seen in the sense that going to be seen here around 30, you can consider it 30 or else to 30 to 35 also can be seen it. So this is what, okay, 30 mm of Hg mercury. Okay, so this is what. And the third one we have to see now. Third one here, hydrostatic pressure. Hydrostatic pressure in the sense here Bowman's capsule hydrostatic pressure. Now let us say here, when I am mentioning here is a Bowman's capsule like this, and this is visceral layer, and this is parietal layer. Between that here there will be water content, right? This is water content, and this going to be a solution, can be seen it here, solution or water you can mention it. Okay, this going to be create a pressure. This pressure will not allow the fluid to come out. Already water is there, no? Then again why it will allow the water to be come down? So that pressure going to be again opposes. Now this is what here glomerular, sorry, one second. This pressure is called here hydrostatic Bowman's capsule pressure. Okay, this can be seen approximately 15 to 20 mm of Hg. Okay, this is also I'm going to be show the same diagram, you can see that now. So now the same diagram, right? Now this one you can see that now you can see that in the Bowman's capsule the fluid is there, no? This going to be opposes, the yellow color one I am drawing. So now opposing this one, this is opposing. So now this we are considering here hydrostatic glomerular pressure. Okay, hydrostatic glomerular pressure. Okay, so now this is how much this is going to be seen it here, 20 mm of Hg. So now how many opposing pressures? Two opposing pressures. How many favoring pressure? One favoring pressure. So now net filtration is equal to, now we will write it here, net filtration. Net filtration is equal to okay, favoring pressure minus opposing pressure. So now what are the favoring pressure here? Favoring pressure will be here, that is GHP, meaning glomerular, this is also can be called here GCP, right? Glomerular capillary pressure minus BCOP, blood colloidal osmotic pressure minus hydrostatic pressure of Bowman's capsule. Okay, so now what happens here? This is 60 minus 30 plus 20. This together you can consider here 10 mm of Hg. Now because of this 10 mm of Hg, that blood going to be of a filtered as a GF. You got it? So this is what here, net filtration. Got it? Very good. Now we go with your content. Content we will read it, so you will understand clearly. Now let us go to the content. This and all we studied, we did not. Now you can see that here, the glomerular capillary pressure. Glomerular capillary pressure is a pressure exerted by the blood in the glomerular capillaries. It is about 60 mm of Hg. Okay, it may varies here 45 to 70 mm of Hg. Glomerular capillary pressure is the highest capillary pressure in the body, and it favors that glomerular filtration. Okay, this is the highest pressure in the body. You see here, entire body itself they are mentioning this is the highest pressure in the body, and this is a favoring pressure. And next one is that colloidal osmotic pressure. It is the pressure exerted by the plasma proteins. As I said to you, albumin will be that most abundant protein in the plasma. Is a glomeruli. The plasma proteins are not filtered through the glomerular capillaries, remains in the glomerular capillaries. And these proteins develop a colloidal osmotic pressure. Colloidal osmotic pressure. That will be around here 25 mm of Hg. It can be like a 20 also can be seen it. 25 mm of Hg. It is going to be opposes this glomerular filtration. This is the opposing pressure. And when it comes to here, you can see that hydrostatic pressure in the Bowman's capsule. It is the pressure exerted by the filtrate in the Bowman's capsule. The water content, the filtrate present in the Bowman's capsule going to be opposites again. This is also. It is also capsular pressure. This is about 15 mm of Hg. That we can consider it's here like a 20 also. 15 to 20 can be seen it. It's going to be opposes this glomerular filtration. So the net filtration pressure is equal to what we will mention it here, favoring pressure minus opposing pressure. So now the balance between this favoring filtration and then pressures of opposing filtration, and this is otherwise known as effective filtration pressure or essential filtration pressure. Now the glomerular capillary pressure minus colloidal osmotic pressure, hydrostatic pressure in the Bowman's capsule together, when we are seeing here, this is going to become like this. Okay, so in the NCRT of +2, it is a 10 mm of Hg is given. In the medical book, it is given like a 20 mm of Hg. Once you check it out, this. Okay, so the net filtration pressure will be like here 20 mm of Hg, and it maybe varies from 15 to 20 mm of Hg. And now we go with that Starling hypothesis or Starling forces. The determination of net filtration pressure is based on the Starling hypothesis. This is a scientist's name. His hypothesis is there. Hypothesis in the sense where there is no proof of that one. Imaginating and telling. Okay. The Starling hypothesis states that net filtration through the capillary membrane is proportional to hydrostatic pressure difference in the across the membrane minus oncotic pressure difference. Now, this hydrostatic pressure within the glomerular capillaries is the glomerular capillary pressure. As this is going to be said by this Starling forces. Okay, Starling forces we can mention it, or Starling hypothesis we can consider it. Filtration fraction or filtration coefficient we have to see now. Filtration coefficient is equal to here the GFR in terms of the net filtration pressure. It is the GFR per mm of Hg of a net filtration pressure. For example, when the GFR is 125 ml and net filtration pressure is the 20 mm of Hc. So now it's going to be seen that here the pressure, because of the pressure, 6.25 ml of going to be produced here. For one pressure, for like a little 20 ml, 20 mm of Hg, 6.25 ml of filtration going to be come and stay in this Bowman's capsule. Hope you got it. The factors regulating this GFR. Factors regulating the GFR, many are there, like RAS mechanism and all those things that we are going to be discussed. It is the most important factor that is necessary for the glomerular filtration. GFR is directly proportional to renal blood flow. GFR will be directly proportional to renal blood flow. Renal blood flow here, that is RBF. How much that RBF comes, that much the GFR going to be produced. So now I already mentioned to you around 1100 to 1300 ml of blood going to be passed into this glomerulus per minute. So now the renal blood flow itself is controlled by autoregulation. It's going to be controlled. That autoregulation refers to that previous chapter also it can be given. The tubular glomerular feedback. Tubular glomerular feedback is that mechanism that regulates GFR through renal tubule macula densa. The macula densa is that juxtaglomerular apparatus in the terminal portion of a thick ascending limb is sensitive to that sodium chloride in the tubular fluid. Juxtaglomerular apparatus, the terminal portion of the ascending limb is sensitive to that sodium chloride solution. Okay, I mean sodium chloride. When the glomerular filtrate passes through this terminal portion of a thick ascending limb, the macula densa act like a sensor. It detects the concentration of a sodium chloride in the tubular fluid and accordingly alters that glomerular blood flow and GFR. Now, the macula densa detects the sodium chloride concentration via sodium plus potassium and chloride contraporter, that is NKCC2. Okay, CC2. Now here sodium chloride, potassium and then chloride ions together, it's going to be find it out. This is contra transporter, you can see that. Okay, co-transporter, contra I mentioned, sorry, co-transporter. When the concentration of a sodium chloride increases in the filtrate, now the GFR going to be decreases. When this is going to be, it decreases, the sodium chloride increases in the filtrate. Macula densa releases that adenosine from the ATP. Adenosine causes the constriction of a afferent arteriole. So, the blood flow through the glomerulus decreases, leading to the decrease in the GFR. Adenosine act on afferent arteriole via adenosine A1 receptors. These are several factors which increases or decreases the sensitivity of a tubular feedback. So now thromboxane. These factors I am just checking. Wait a minute, I'll explain to you. And then atrial natriuretic peptide, and next one prostaglandin I2, cyclic AMP, nitrous oxide. So these factors decrease the sensitivity of tubular glomerular feedback. These factors increases good thromboxane. So adenosine going to be released from the ATP. Done. And now thromboxane and prostaglandin E2 hydroxy ecostatonic acid. Done. Okay. DFR going to be decreased, and this is, yes ma, how it's going to be regulates we are going to be discussed now. RAS mechanism they did not give you, I'm just checking, wait a minute. Yes, I'm going to be explained to you 1 minute. Now we see that what we are discussing now, this filtration fraction is over, that how it's going to be regulating of uh, renal blood flow, regulation of renal blood flow we are going to be discussed now. Regulation of renal blood flow, if you are considering, you see, it's directly proportional to GFR directly proportional to renal blood flow. Okay, here what happened, first let us go with the juxtaglomerular apparatus. Now let us say here this is a Bowman's capsule, and it's going to be have it, this is Henle's loop. I'm just drawing the small one for explanation purpose. So now you can see that. Okay, and now what happens? In this one, afferent arteriole is there. This is afferent arteriole. This is afferent arteriole, and here is that going to be divided like this, and this is efferent arteriole. This is efferent arteriole. You just imagine like this. Okay, chuma. And now we go here. This is DCT now. Now the DCT will go and communicate with that afferent arteriole. Right? Very good. Now the area where it's communicating, that region, both in afferent arteriole and DCT going to be modified. Okay. So now here this is this area, and this area going to be modified. That afferent arterial area where it's going to be communicate with the DCT is called juxta cells, juxtaglomerular cells. Okay, you can consider JG cells, simply JG cells. When it comes to here, this modified cells are called here macula densa. Okay, macula densa is that modified epithelial cells of a DCT. Juxtaglomerular cells here, modified epithelial cells of a afferent arteriole. You got the clarity. Now let us go here. Function of this macula densa. Macula densa act as a receptor. So what it's going to do, whenever that the glomerular filtrate passing through this ascending limb, this is a ascending limb of a Henle's loop, it's a passing towards this DCT. That particular period, it's going to be like a receptor, right? It's sensitive to that. Sensitive means it's going to be recognized. NaCl quantity if it is increased, okay, NaCl quantity if it is increased or decreased, it's going to be recognized. The same way, blood flow if it is increased or decreased, GFR if it is increased or decreased, blood volume if it is increased or decreased, anything going to be recognized by this one. Okay, anything means like these are all the factors. Sodium ions increased or decreased in the blood flow will be increased or decreased, GFR will be increased or decreased, blood volume is increased or decreased, everything going to be sensitized by this macula densa. After sensitizing, what it's going to do? After sensitizing, it gives the signal to macula densa. Macula densa sends the signal to JG cells. JG cells. Now the JG cells, what it's going to do here? Renin going to be produced. Renin. Renin is that here hormone-like substance produced from the juxtaglomerular cells. You got it? Renin. This is a hormone actually. This is hormone. Got it? Now let us say here what happens. According to your medical book, they have been given when this glomerular filtrate passes through ascending limb of Henle's loop, what happened? It's going to be recognized that sodium chloride ions, potassium ions together you can consider like a co-transporter. Okay, if it is less or if it is more, this is going to be recognizes. As a result, what happened here? It's going to be produces adenosine. Adenosine, what is this adenosine? Let us go here. We have like in the DNA adenine, guanine, cytosine, thymine. Can be seen it, right? This adenine, if you are considering, this is a nitrogen basis. Adenosine, if you are considering here, this is nucleoside without phosphate, nucleoside. Okay, and adenosine triphosphate. This is here we can consider like a ATP, energy giving molecule. Done it. So now here this one. Next one is that here adenosine only we are talking now. That adenosine going to be produced. When the adenosine is produced here, sensitivity going to be increases. So now any decreased BP, blood pressure, decreased blood volume or decreased or increased anything, okay, going to be recognized. Sensitivity going to be increases, okay, and decreased sodium ions or increased sodium ions going to be recognized because of this adenosine which is produced into the filtrate. Not only this one, some of the factors told in the textbook, okay, all those things going to be increases that sensitivity. And opposing of this one, there is some other things are there, those going to be decreases that pressure. Okay, now let us say here that is what they have been mentioned in this one. Okay, one second. You can see that here. This is co-transporter we mentioned. And next to go with that, next page when they are giving to you, next page. Here you can see that. This is the ATP. From the ATP, adenosine going to be produced, which going to be constrict this afferent arteriole. Afferent arteriole diameter going to be decreased. When the afferent arterial diameter is decreased, blood flow going to be speed ups, means blood pressure going to be increases. Got it? So decreases, leading to decrease in the GFR. Through the glomerulus, here decrease in the GFR. So here adenosine causes that constriction of this afferent arteriole, so that blood flow through the glomerulus decreases, leading to the decrease in the GFR. Adenosine act on the afferent arteriole via adenosine A1 receptors. Okay, and next the several factors. Now this is the question they may ask you, that which of the factors can be increases that sensitivity on this tubular feedback na? Then adenosine, thromboxane, prostaglandin E2, hydroxyeucostronic acid. Okay, which is going to be decreased in the sense atrial natriuretic peptide. Okay, and prostaglandin I2, here E2, here I2, and cyclic AMP and nitrous oxide. These are all those things. Hope you got it. And now it's going to be here macula densa. When the GFR going to be decreases, macula densa give the signal to that RAS mechanism. Okay, prostaglandin E2, bradykinin and renin going to be produced here. Okay, so when the GFR is decreased, then what happened? Renin going to be produced. Renin produces in a sense along with that prostaglandin E2 and then bradykinin. Okay, bradykinin going to be produced. Now this bradykinin and this E2 going to be cause a dilation of the afferent arteriole. When the dilation going to be increases here, then what happened? Renin induces the formation of a angiotensin 2. And this caused the constriction of efferent arteriole. Okay, when the efferent arteriole going to be constricted, then dilation of afferent arteriole, and then constriction of this efferent arteriole leads to that increase in the glomerular blood flow. Okay, you got it, ma? What they are mentioning? First here is that constriction of this afferent arteriole is taking place. Constriction in the sense diameter going to be decreased. This is what here. Constriction in the sense diameter going to be decreased. When the diameter is decreased here, glomerular blood flow going to be decreased. So as a result, GFR is also decreased. Now afterwards what happened here? Efferent arteriole is also constriction takes place. When the efferent arteriole constriction takes place, automatically afferent arteriole going to be broad enough. So as a result, the pressure going to be altered. Okay, I'll explain through this paper so you will understand. Now usually what happens here? This is afferent arteriole. Afferent arteriole, what happens here on the afferent arteriole? Adenosine, okay, prostaglandin E2, okay, and then some other thromboxane. So these are all what it's going to do. It is going to be constrict the afferent arteriole. Because of this one, what happens when the diameter decreased, blood flow decreased. When the blood flow is decreased, automatically GFR going to be decreased. When this afferent arteriole becomes narrow, already while I'm drawing the diagram, efferent arteriole also I told like this is a narrow, right? So that is narrow only, it is there. This is narrow only, it is there. Okay, now you see what they are mentioning. This is narrow already, and this one like this. You got it? So now when this diameter going to be decreased, blood flow decreased, and this is what decreasing, right? So this particular period, what happens here? Glomerular filtration rate going to be decreased. When the glomerular filtrate rate is decreased, blood volume is also going to be, checked it out here, volume going to be decreased condition, sodium ions decreased condition. All those factors will make here JG cells to release renin. Not only renin here, bradykinin, and then prostaglandin, E2. Prostaglandin actually act on the smooth muscle. Okay. E2 going to be produced. This going to be produced. When these are all produced here, now what happens here? This going to be make it constriction of okay, efferent arteriole, okay, and then dilation of afferent arteriole. So as a result, what happened here? Again the blood volume going to be comes downwards. It's going to be decreased, it's going to be done it. Now the renin, what it's going to do? Renin going to be act on the angiotensinogen, which is produced in the liver. Okay, through the blood it will reach here. Angiotensinogen into angiotensin 1. Okay, now this angiotensin 1, due to the renin only, it is a converting. Now this angiotensin 1 going to be converted into angiotensin 2. This is done by ACE. This is angiotensin converting enzyme. This angiotensin converting enzyme given by lungs. You see here, angiotensin comes from the liver, renin comes from the kidney, from the lungs here this ACE will come. So ultimately we got here angiotensin 2. Once the angiotensin 2 is formed here, it will do the two functions. One is here blood vessels constriction, because this angiotensin 2 is that vasoconstrictor ಇದೆ. Okay, that's what here blood vessel constriction going to be seen it. And next one is that here another function is nothing but it acts on the adrenal cortex. From the adrenal cortex, what happens here? Aldosterone will come. Aldosterone is that one of the mineralocorticoid. Okay, now this aldosterone going to be, okay, aldosterone mineralocorticoid, right? So now this blood vessel, when it's a constriction takes place, blood pressure going to be increased. As a result here blood volume going to be checked it out. Okay, checked out, and glomerular filtration rate is also checked out. Now here what is the importance of this aldosterone? In the sense, main function of aldosterone here, sodium ions going to be reabsorbed from the DCT, right? And now here one more also it will do, phosphate and potassium elimination or excretion going to be increased. Excretion it will do. It is also this aldosterone also will do one more function, that is nothing but here blood pressure and osmotic pressure regulation. So these are all done by this aldosterone. So this entire thing you can consider like a RAS mechanism. RAAS. Now you see R for renin, A for angiotensin, one more A for here, that's the aldosterone, and this is system. Okay, RAS mechanism. Through this one it's going to be controlled. Hope you got this one, right? And now we go with that. That is only they have been mentioned here. So we are discussing this one. Okay, so RAS mechanism you understood now. And now glomerular capillary pressure, already we discussed. Glomerular capillary pressure directly proportional to capillary pressure. Normal glomerular capillary pressure will be 60 mm of Hg. When the glomerular capillary pressure is increasing, GFR is also going to be increases, directly proportional. Okay, glomerular capillary pressure is increasing, then GFR is also going to be increased, and in turn depends upon the renal blood flow and arterial blood pressure. Colloidal osmotic pressure. Colloidal osmotic pressure inversely proportional to glomerular filtration pressure is inversely proportional to osmotic pressure. If your blood colloidal osmotic pressure is increased, then GFR going to be decreased. Inversely proportional. GFR going to be decreased. Okay. So now here the plasma proteins that are glomerular capillary blood, normal colloidal osmotic pressure is 25 mm of Hg. When the colloidal osmotic pressure is increases, as in the case of dehydration, important dehydration time, what happened here? Blood colloidal osmotic pressure going to be increased. So that particular period, what happened here? The level of GFR going to be decreased. GFR going to be decreased. When colloidal osmotic pressure is low, as in the hypoproteinemia, then GFR going to be increases. You understand, ma? So now you see here, dehydration happens. That means from our body more blood pressure is going. When from our body more water is going out. When the more water is going out, that particular period, what happened here? This osmotic pressure, that is colloidal osmotic pressure, increases. When more water is going from our body, osmotic pressure going to be increases. That is colloidal osmotic pressure. Okay, or else you can consider the increased plasma protein in the level of GFR going to be decreased. Plasma protein going to be decreased, GFR decreases. Okay, increased plasma protein level where it's going to be decreases the GFR. Done it? Very good. When colloidal osmotic pressure, when colloidal osmotic pressure is low, then what happened? It's going to be like a hypoproteinemia. More proteins are there, hyperproteinemia. Okay, proteinemia. And hypoproteinemia means less proteins are there. Less proteins means more osmotic pressure. More proteins means less osmotic pressure. Reverse I told. 1 second, ma. More proteins means more colloidal osmotic pressure, because of proteins only it's going to be created this pressure. Okay, more proteins means more osmotic pressure, colloidal osmotic pressure. Less proteins means less colloidal osmotic pressure. Okay, so that's about here. And now you see here hydrostatic pressure in the Bowman's capsule. Hydrostatic pressure in the Bowman's capsule here, it's going to be 15 mm of Hg. The hydrostatic pressure increases the Bowman's capsule and decreases the GFR. That means this is also inversely proportional to GFR. Okay, and hydrostatic pressure in the Bowman's capsule increases in a condition of obstruction of urethra or edema of the kidney beneath the renal capsule. Urethra in the sense here, especially male. Okay, common passes for that semen as well as this urine passes, right? In female, urethra passes will be separate and urethra passes will be separate and reproductive passes will be separate. So now here, this is what that means. That urethra, that's the end portion of urinary bladder. Okay, that urethra, if any obstruction is there, something is blocked there, means then this glomerular filtration pressure going to be hydrostatic pressure going to be increases, so that glomerular pressure going to be, glomerular filtration rate going to be decreases. And edema occurs in the sense here, any dysfunction of the kidney means then swelling of our body occurs, that's because of this one. Okay, good. And now constriction of afferent arteriole. Constriction of afferent arteriole reduces the blood flow to the glomerular capillaries. Okay, so which in turns that reduces that GFR. Usually constriction of the blood flow will be passes that blood pressure will be increases, we used to mention, but here afferent arteriole, if it is reduced, as a result what happen, it reduces that GFR flow. Okay, that you remember it. Okay, so now here it's going to be constriction going directly proportional to GFR. If it is constricted more, GFR will be less. Okay, GFR will be less. This is inverse lemma. Okay, done. Constriction of efferent arteriole. Constriction of efferent arteriole, initially the GFR increases because of the stagnation of the blood in the capillaries. Later, when all the substances are filtered from the blood, then further the filtration does not occur. It is because of the efferent arteriole constriction prevents the outflow of the blood and glomerulus. So no fresh blood enters into this glomerulus for the filtration purpose. So this is also helping you see. Beginning period, if it is a constriction of efferent arteriole happens, diameter going to be decreased means, of course, glomerular filtration going to be increased for a certain level only. A particular thing, it is like all the nitrogenous waste and all, it's going to be filtered means, and still more it will not allow this glomerular filtrate, that particular bit opposes. That's what they have been mentioned. And systemic arterial pressure. Systemic arterial pressure in the sense the renal blood flow and GFR not affected as long as the mean arterial pressure is between that 60 to 180 mm of Hg. Mean arterial pressure in the sense overall total arteries, the pressure how much it is there. The largest artery is nothing but aorta, and then there will be arteries after arterioles, and then capillaries. These all will carry the oxygenated blood, and these blood vessels, the pressure going to be decreases and increases also will make here GFR rate going to be fluctuated. That's what here the mean arterial pressure in between the 60 and 80 mm of Hg, that particular period it will not affect that GFR. If it is a little bit lesser or increased means, then it's going to be affected. So this is due to that autoregulatory mechanism. And variation in the pressure like above 180 mm of Hg or below 60 mm of Hg, that going to be affect this GFR. Okay, autoregulatory mechanism already is present in the kidneys, right? So that's about. And next one is that sympathetic stimulation. Sympathetic system going to be mainly act that constriction of the blood vessels, relaxation of the blood vessels, and all those things here. So you know very well that ANS is nothing but here autonomous nervous system going to be divided into sympathetic nervous system and then parasympathetic nervous system. The sympathetic nervous system, parasympathetic nervous system, if you are considering here, sympathetic nervous system going to be increases almost all the functions except that digestive tract, like a heartbeat increasing, respiratory rate is increasing, pupil dilation going to, pupil means eye pupil dilation going to be seen it here. And also you have to see like blood vessel constriction, and then it's going to be like increases the adrenaline production and all those things here. Whereas parasympathetic, except the digestive tract, the remaining all going to be of a decreases, like gastric secretion going to be increases, and then digestion, deglutition means swallowing, that going to be controlled by this, peristalsis going to be controlled by this in such a way. Okay, you got now one idea. Now let us say here, thus afferent and efferent arterioles are supplied by the sympathetic nerves. This is supplied by the sympathetic nerves. The mild or moderate stimulation of sympathetic nerves does not cause any significant change either that renal blood flow of a GFR. Okay, so afferent and efferent arterioles supplied by the sympathetic nerve always will be there, and mild moderation can be seen it here. That mild moderation, whenever that our body is required, the body is required, it's going to be cause that significant role on this GFR. Strong sympathetic stimulation causes that severe constriction of the blood vessels by releasing that neurotransmitter, that is noradrenaline and adrenaline. The effect going to be more on the efferent arterioles than that of afferent arterioles, so that initially there is an increase in the filtration, but later it's going to be decreases. However, if this stimulation continued for more 30 minutes, there is a recovery of both the renal blood flow as well as GFR. If it has to be done, because the renal blood flow is that so much of less means again it's going to affect our body. So that's what on 30 minutes what happened here is going to be constriction takes place because of this sympathetic nervous system. Sympathetic nervous system main function is nothing but constriction of the blood vessels. So which blood vessel is the thing here, important here? That is nothing but a efferent arteriole. On the efferent arteriole, it's going to be create that more effect here, and more impact can be created on efferent arteriole, where it's going to be produces adrenaline or noradrenaline. This going to be act on that. So as a result, blood vessel constriction going to be takes place. Blood pressure will be increased, so that glomerular filtration rate is also increases. That's what. The surface area of a capillary membrane, GFR is directly proportional to surface area of the capillary membrane. So GFR means that's if it is a capillary, how many capillaries are there, and capillary diameter, capillary area, this physics terms, if it is there, how much that area volume, how much it is there. So that much going to be here. GFR is also can be seen it. So that's what here GFR is directly proportional to this surface area of this one. Okay, and permeability of the capillary membrane. GFR is directly proportional to permeability of the glomerular capillary membrane, because glomerular capillary membrane, how much it's going to be have the ability to send the fluid out, that much GFR will be produced. So the permeability in the sense the pores, the allowing of this fluid to come out. Okay, that is what here. And many abnormal conditions like a hypoxia meaning there is no oxygen to the body cells that particular period, lack of blood supply, some sort of a conditions, any blockage of this blood vessels or something, what happened, the lack of supply can be seen it here. The presence of toxic agents, some people will take like some of the toxic substances or suicide attempts or something like that. That particular period, the permeability of the capillary membrane going to be increases. Such conditions, even plasma proteins also filtered and excreted in the urine. So now presence of proteins in the urine indicates that abnormal. Okay, usually the protein should not be there, right? So now the presence of protein is there means blood vessels, capillary membrane permeability is increased. Capillary membrane permeability, why it is increased? Maybe in our body some abnormality like oxygen going to be less here, or else lack of blood supply somewhere, or else here that's a toxic agents are there. So that is what. And next one is that constriction of glomerular mesangial cells. Glomerular mesangial cells. This mesangial cells, where it is present, I will tell you. So you will understand that. Okay, mesangial cells in the sense, this is juxtaglomerular apparatus is there, no, where that's going to be afferent arteriole, and then this distal convoluted tubule going to be communicate here. We just discussed now afferent arteriole, and it's going to be seen that efferent arteriole like this. In between of this one here, that mesangial cells will be present. This is the area mesangial cells. If you type in the Google, and it will show to you. Okay, so this is what mesangial cells. Now this mesangial cells are situated between this glomerular capillaries. Okay, glomerular capillaries means afferent arteriole and efferent arteriole between, and this going to be here contraction of these cells. These cells decreases the surface area of the capillaries. This going to be decreased means surface area is also decreased. When the surface area is decreased, automatically GFR going to be decreased. Okay, And what are the hormones and other factors going to be affect this one, in the sense hormones and other factors here which affect this blood flow through the glomerulus, that is atrial natriuretic factor. Atrial natriuretic factor, ANF, you can consider it. This comes from the atrial wall of the heart. ANF going to be against of here that's a renin, means RAS mechanism. This is against of ADH, that is ADH, antidiuretic hormone or vasopressin, you can consider it. This is also against of aldosterone. So these are all going to be RAS, aldosterone, and then ADH going to be increases that blood volume, increases that glomerular filtration, increases that sodium reabsorption and all those things, whereas ANF going to be decreases. Natriuretic factor. This sodium is a chemical name, is nothing but natrium. That's what we used to write Na. We will not write SO, sodium. So now natrium in the sense here, so sodium. So atrial natriuretic factor. Okay. So now this is against of all those things. This sodium reabsorption going to be prevented by this ANF. So that is what here natriuretic factor and natriuretic peptide. Brain natriuretic peptide. Brain is also going to be produce that natriuretic factor, CAMP, cyclic AMP. And dopamine, happy hormone also we can consider it. Happy hormone, sometimes what happen here, this is going to be act as a inhibitory neurotransmitter. Serotonin and dopamine, these are all inhibitory neurotransmitter, like it's going to be act here. Endothelial derived nitric oxide and prostaglandins, E2. Okay, these are all going to be some of the chemicals which going to be affect here. And factors which decreases that GFR, here, angiotensin 2, that's what RAS mechanism going to be decreases. Factors decreasing the GFR by the vasoconstrictin, angiotensin 2, and then endothelium, noradrenaline, platelet activating factor, and platelet derived growth factor, prostaglandins. Okay, F2, prostaglandin F2, you have to remember it. Okay, only 1 second ma. Factors increasing the GFR by vasodilation. So now this is vasoconstrictor, ADH. Now this is vasodilator. Vasodilator going to be increase that GFR. Vasoconstrictor going to be decreasing that GFR. Okay, done. That's about here. Now till here is that only one step we discussed, that is glomerular filtration. Next it's going to be followed by this tubular reabsorption. Tubular reabsorption, that going to be here from the glomerular filtrate. Most of the filtrate going to be 99% of the filtrate going to be reabsorbed, okay, into this peritubular capillaries. Done. So now the substances move into that peritubular capillary. First it will come to that interstitial space of the kidney. From there it's going to be enter. The substances are taken back into that blood from the glomerular filtrate. Entire process is called here tubular reabsorption. The method of collection of fluid, this they are going to be teach you in the medical terms. These are all okay. You can read and you can see this one. Okay, and next we go with that selective reabsorption here, that is reabsorption going to be taken from the tubular cells, only substances necessary for the body, and essential substances which are going to be glucose, amino acid, vitamins are completely reabsorbed, and then which is not necessary will be given to that. Let us have an idea here which are the substances going to be reabsorbed. So we are going to be discussed now. This is PCT, this is here Henle's loop, and this is here DCT, and here is that collecting duct. You just imagine like this. And reabsorption, when the aroma comes out, that's a reabsorption. From here PCT, what happened, this maximum water, okay, that is a 70 to 80% of water and electrolyte going to be reabsorbed in a PCT. So now water and then glucose and then sodium and then chloride ions and then amino acids, okay, all those things going to be reabsorbed. Okay, when arrow mark goes inside at this region here, ammonium ion and then H plus ions going to be enters. Because of this one, what happened, bicarbonate ion going to be reabsorbed. Important, bicarbonate ion going to be reabsorbed. Bicarbonate ions thana varadu, okay, because of this it itself will not come, it is because of this going to be comes. Okay, done. And when it comes to here the fluid, it becomes here hypo, this is isotonic, sorry, here is that isotonic, can be seen it isotonic. And when it's coming downwards, this is descending limb of a Henle's loop. Descending limb of Henle's loop is that permeable only to the water. When the water alone is taking here, then the fluid becomes here hypertonic. Here it becomes hypertonic. Okay, and this is almost impermeable to the ions. When it comes to here ascending limb, this is ascending limb. Ascending limb going to be ascending limb of Henle's loop. Ascending limb of Henle's loop is that permeable to the ions and impermeable to this, impermeable to the water. So that means here sodium ions and then potassium ions and then what is that, magnesium ions, calcium ions. Okay, these are all going to be of a reabsorbed here. Done. And in this one here, the thin segment here, in this one ascending limb and descending limb going to be thin and thick segment will be there. The thin segment, if you are considering here, urea going to be entered, I mean secreted. Whenever that arrow mark is going inside, you have to remember secreted. Now the urea going to be entered into this filtrate. From where this urea is coming? From the collecting duct it's going to be comes. Okay, collecting duct it comes. So this is, and next we go with the DCT. And now it becomes here hypotonic. Here hypotonic, it became hypotonic solution. Okay, and next what happened here, it enters into the DCT. In the DCT what happened, this going to be depends on the hormones only, the reabsorption. Hence you can consider this as a conditional reabsorption. Reabsorption we will consider it. So now this is, we are considering like with the help of ADH, water reabsorption will be taking place. With the help of aldosterone, it's going to be take here Na plus ions. With the help of PTH, okay, parathyroid hormone, calcium ions reabsorption will be takes place. As well as at this area secretion is also taking place. Okay, that secretion ammonia, okay, H plus ions and potassium ions. Here potassium ions reabsorption can be seen it, potassium ions, and secretion cannot be seen in the PCT, whereas here secretion is also can be seen. And what about this, what about this collecting duct? Collecting duct, okay, water reabsorption can be seen it, and then some of the ions like a sodium reabsorption can be seen it, as well as urea reabsorption can be seen it. Into this one here, ammonia, as usual, whatever happens in the DCT it's going to be, and then H plus ions, okay, and then it's going to be potassium ions going to be released into the filtrate. And here one particular thing I forgot to tell, whenever these three are going to be increases, I mean released here, then what happened, there is a reabsorption of bicarbonate ion. Okay, done. So now PCT going to be help here, osmotic balance and then pH balance, PCT and collecting duct. Okay, and then what about this Henle's loop? Henle's loop going to be increases that concentration of a GF, glomerular filtrate. And what about the DCT? DCT going to be help here to maintain potassium and sodium, okay, potassium sodium ion balance, and pH also it maintains. Okay, done. So this is what here reabsorption and secretion. So hope you understood. You try to read it again. So if it is useful, that's better. If it is not useful, you try to deal it yourself. Okay, done. Thank you. Bye bye.